Hi everyone, my name is Kelsey, and I was debating the con side of having family members consider care partners in critical care areas. Thank you to everyone who took part in the debate and the rebuttals with your comments and feedback. And thank you to my partner Cecilia, my opponent for the debate, challenging me to investigate more onto this side of the debate. Now think of yourself in a high stress, high stakes situation and how you'd feel. Now, in this state, if medical professionals are asking you to be involved in making decisions and care for your sick and possibly dying loved one, with little to no preparation time, and these decisions having a huge impact on their outcome and well-being, would you feel prepared? This exact scenario is how a vast majority of family members feel when a loved one is admitted to intensive care. Families feel increased levels of stress and anxiety when they're subject to care partners in critical care areas. Right off the bat, ICU environments are very unwelcoming to family members. With limited space at the bedside, cramped waiting rooms, and intimidating equipment and technology providing life-sustaining measures to ICU patients, the ICUs are made for patient survival, not family comfort. Even with influential organizations such as the World Health Organization and the Society of Critical Care Medicine reinforcing the concept of family-centered care, their guidelines give no concrete recommendations as to how to apply these notions into practice, with even the Society of Critical Care Medicine quoting in their own guidelines, all 23 recommendations in these guidelines were weak recommendations, reflecting the relatively low quality evidence regarding the interventions to improve family-centered care. While family-centered care isn't a new concept, there is a lack of high-quality research supporting the concepts in critical care settings, posing a challenge for individual practitioners to abide by these concepts without support or guidelines. To circle back to my scenario at the beginning, family members are often placed as a surrogate decision maker when family members are incapacitated in intensive care settings. As demonstrated in the research, most family members, as mentioned, lack preparation for this responsibility, with emotions running high and having a lot of difficult, heavy information to process. To communicate with family members under these circumstances, with limited medical knowledge, time constraints, and religious and ethno-cultural influences, this can lead to conflict among team members and family members, as well as an increase in personal stress levels and anxiety levels for families that can carry over past the ICU visit. Patient instability and unknown outcomes leave families frustrated for answers and may give pushback to physician recommendations to stop futile treatment, with conflicting views becoming incommodious to staff and family alike. This amount of stress and pressure does not serve families well when participating as active care partners in care. Performing tasks such as simple ADLs still need nurse supervision, which they may not have time for, plus the fear from family of doing something wrong or hurting their loved one, and sometimes they don't want to participate at all. In closing, until more evidence is conducted to show measurable benefit to involving families in care in critical care settings, it's best to keep the roles distinct to let healthcare providers do their primary role in care for the patient and have family members simply be present for the patient, not a care partner. In a critical state, most would agree that saving the patient's life or helping them to die a comfortable, dignified death is most important in the end. Thank you.